All right. We're gonna get the show on the road here as soon as I remember how to do all of this. It's been a bit, hasn't it? All right, I think we're good to go there, and there. All right, good to see everyone. I haven't done this in a while, which makes me even more excited to get this done. Let's make sure we share it over to the group so the group can see it. There I am. Okay, and how do we share this thing again? Summer is over, so we're kind of back and doing things yet again, which is exciting for us. So hopefully you guys are excited because we're kind of back to doing things in the normal way now that I'm kind of back in the office and doing things. So excited to hear how your summers were and kind of get back into things. And so before we get started, what we're going to be talking about today is a respiratory failure patient that I gave you this morning, and we're going to kind of break it down and talk about kind of the things that we can do in this particular situation. So before we kind of get started, and just kind of while people are kind of making their way into the class, why don't you guys let me know where you're watching from? Go ahead, throw that in the comments. I'd love to know where you're all from. I see that Reed is first, and then watching from Kenya. That's incredible. Where else are you watching from here? I'd love to know where you all are at. Baltimore, Utah, UK, Georgia, California, Slojanistan, Naples, Florida. Good luck down there. I know you guys are going through some stuff. Italy, California, Fresno, Florida, Ireland, Charleston, Texas, Oklahoma. That is awesome. Well, it's exciting to see you all here. There it goes. It's exciting to see you all here and kind of getting going. Instagram, you guys are good still? Looks like it, hey? Good. Utah, South Africa, Virginia, Michigan, North Carolina. Geez, you're all over the place. This is awesome. I love seeing this. It always gets me excited to see kind of where you're all from. And so let's kind of get into it and as the UAE, nice. As we are kind of, like I was just saying, that we are talking about a respiratory failure patient. This patient is a challenging patient because these patients do not stay linear. They tend to get better and get worse and kind of just in this really, really awkward kind of like, oh, can we make it to the hospital? Can we not? That's kind of the things that we're dealing with this, particularly this patient that I gave you this morning. And before we get into it, I just wanted to mention that we announced something a couple days ago, which is our FAST Canada conference. I'm from Canada, and we work with the students all over the world, particularly in the United States, Canada, the UK, Ireland, Scotland, you name it. We kind of have students everywhere, as you can see in the chat. But we just partnered with Flightbridge Jet, another education company that runs a conference in the United States, and we're bringing it for the first time to Calgary, Alberta. And so that's something that we're going to be doing. Hopefully you guys are already kind of talking about this, but if you haven't heard about it, definitely something to check out because we would love to see you there. Tickets are going to go on sale in November, but you can hold your ticket for $5 on our website. So you can go ahead and go and use this QR code, or you can message the page, Instagram or Facebook or on TikTok, and just say, hey, I saw this thing about FastCan. Can I get the link for it? And we'll absolutely send it to you. If you're thinking about a group from overseas or a group from from your service, we can set that up as well. Just shoot us a message on the page. Okay. Let's get into the patient itself. Okay, so just making sure that Instagram is working. It's trying really hard. Okay, so you are dispatched to a male patient who is short of breath due to COPD. You arrive on scene and have been treating with oxygen with a non-rebreather, bronchodilators, corticosteroids, and magnesium sulfate, but the patient continues to deteriorate. You're in a rural setting, so you're transporting, and you're about 30 minutes away from the hospital, and you run a set of vitals, and this is what you get. Skin is pale, level conscious fatigued, but conscious, eyes are PEARRL, and you'll see this is kind of the presentation of your patient. Really uncomfortable, kind of leaning over, not having a whole lot of energy. So nothing that's looking good for us in this particular situation. So let's take a look at those vitals. Okay, that's what you see on your vitals here. What do you think? Here, I'm just gonna swap out. Here, Instagram, I'm just gonna swap you out. 1 sec. So what do you think that looking at these vital signs, what is concerning to you right off the hop? Okay. Okay. We got Instagram back on here. So, what is concerning to you when you look at these vital signs? So we have a heart rate of 147, we have a blood pressure of 108 on 70, we have an EtCO2 of 68, and a respiratory rate kind of 9, 10, 11 area, and we have an SpO2 of 83%. 83%. So, as you can see, not good, right? Not good. Instagram, I think you're not good here, as you can see, right? It's not looking good. What are the things that you see here that are really concerning to you? Okay, that's kind of my question. So what are the vitals that mostly are concerning to you? What do you see there kind of go, that's not good, and makes you kind of get worried about what we need to do here? Let's see, what you guys got. The EtCO2, definitely. The slow breathing, the shallow breathing, definitely. Some of you are saying the shark fin on the EtCO2. I totally agree with you. I'm going to talk a little bit about that. Elevated heart rate, always kind of a concern, right? Low SpO2, tachycardia, low SpO2, shark finning. Quite a bit, hey? Like it's kind of, there's a lot going on with this particular patient. Respiratory acidosis, I would almost, yeah, like we know that that's happening. The Zol being on 4%. In my defense, this is a simulated thing, and it takes the battery device, and so I had it plugged in, and it only made it to 4% before I shot this. So battery level is decompensating. I'll give you that. Okay, so yeah, there's a lot to unpack with these vitals. So let's take a look at them. So first off, the heart rate is not good. Like, as you can imagine, like this heart rate is pretty significant at 147. That's a high heart rate, and it's almost certainly due to the hypoxia that we have. And so we see it at 83%. So this heart rate is going to probably start to plummet, actually, as this patient gets worse and worse, and hypoxia becomes worse and worse. And so 147 is not good, because this is kind of probably the top of the tipping point before it starts to really decline into a bradyarrhythmia. So that's something to really look for. The blood pressure itself, 108 on 70. This is not horrible, okay, as from a numbers perspective, but I mean, that shock index is high, okay? That heart rate is far above that systolic pressure. So this patient is barely holding on from a systemic point of view or a perfusion point of view. And is pretty sick. And so even though the number looks good, the combination of things is not good, okay? They're barely holding on here with that blood pressure. So that's something to really kind of take in consideration, especially when we start thinking about treatments that we can do. The EtCO2, 68. So this is all due to the fact that we have a patient that is not breathing appropriately. So they're not able to get CO2 out, and then likely this movement of air or lack of movement of air is causing the saturation problems. And so you have a, let's be honest here, like we have a really, really sick patient that is trying really hard to go into cardiac arrest here. Like they're on kind of that moment. So just based on kind of what we see here from the vitals and knowing that this is a COPD patient, do we think that this is a bronchial problem with this patient, or is this more of an alveolar problem in the lungs with this patient? Go ahead, put that in the comments. Is this a bronchial problem or an alveolar problem? Okay, this is an important question to answer for yourself, so I want you guys to kind of think it through. What do you think? Thinking alveoli. What's TikTok thinking? Alveolar, alveolar, alveolar. Okay, interesting. Bronchial, alveolar problem, alveolar problem. Okay, so let's do a quick little lesson. I'm going to take my pen out yet. Okay, let's do a quick little lesson and kind of understand the difference between a hypercapnic failure and a hypoxic failure in a patient. So that's a very important distinction to make, is a hypercapnic or a hypoxic failure. Now, hypercapnic is all due to airflow, and hypercapnic is when we have elevated hypercapnia or elevated CO2s, which we do in this patient. And so when you have elevated CO2 issues, it's almost certainly due to the fact that they're not able to have or maintain a good tidal volume or a good minute volume, meaning that every breath is really, really limited and they have very few breaths, which is what we're seeing with this particular patient. And it's all due to the fact that we can't move air in or out of these bronchioles, okay? We can't do that because there's an excessive amount of constriction in our bronchioles and an excessive amount of mucus in our bronchioles. And basically, we end up with really, really narrow airways, or in other words, bronchioles. And so in a hypercapnic failure, in COPD in particular, it's actually the alveoli itself are not really the problem. They're not filled with fluid. They're not really damaged in any way, particularly as long as we have no other issues going on. What our problem is the tubes or the highways running to the alveoli are constricted. And so this is kind of a bronchial problem. What would be an example of an alveolar problem is that if we had fluid or any type of immune process in the airways. So think of patients that have pulmonary edema and congestive heart failure. That's an alveolar problem. If we have patients that have acute respiratory distress syndrome, they have an immune process in their lung or in their alveoli. That's an alveolar problem. And if we have patients that have pneumonias that are leading to alveolar ARDS, those are alveolar problems. And so they have problems getting oxygen from the alveoli into the blood. So that's the other side of the fence. Our side of the fence that we're dealing with this patient right now is all due to air movement and air trapping, which is a hypercapnic or bronchial problem. Okay, so all in all, this is a bronchial problem that we're dealing with this COPD patient. Okay, and that is and so when you're thinking hypercapnia, you can think of airflow. That's the issue that we're having with this patient. And essentially what happens is that we have all of this blood, okay, that's running past all these alveoli, okay? And the CO2 is trying to offload into here. But the problem with these patients when they have poor tidal volume and they have poor airflow because these bronchioles are constricted and they're restricting that airflow is that the alveoli are basically full of CO2, okay? And then they get so backed up and we don't have time to get the CO2 in the blood off into the alveoli. And so essentially what happens is that CO2 accumulates in the blood because it doesn't get an opportunity to get into the alveoli. And when it accumulates in the blood, like we're seeing here, that's where our hypercapnia comes from, is because it's missed its opportunity to get off the bus into the alveoli to be excreted. So it just stays in the blood. And that's where we get our metabolic or a respiratory acidosis from. Okay, so CO2 is accumulating in the blood as you can see here. And so when that occurs, when we do get the opportunity to get the CO2 off the bus and into the alveoli, it kind of rushes it. Okay? And when it rushes it, like we see here, that's where we get those really, really high end-tidal CO2 numbers, because they're breathing all this really highly concentrated CO2 that's trying to get off the bus all at the same time. So that's where you get your hypercapnia from. It's because an accumulation of CO2 in the blood and all trying to get off into the alveoli at the same time when the opportunity presents itself. And that's what gives you your hypercapnia and your high levels of end-tidal CO2. Okay? So now we know kind of what the problem is. We have a bronchial problem. We have an issue with accumulation of CO2. And we have a patient that's kind of on the teetering edge right now. So my question to you is, what treatment could we try at this point for this patient? What treatment could we try? So Jets Jones thinks CPAP, and if no result or no result, upgrade to BiPAP. Okay. CPAP. So we've done all type of subbutamol ipratropium bromide. It's failed. Hyperventilating. Okay. Racemic epi. Okay. Hydrocortisone. We've already given the corticosteroids. Right? We've already given the corticosteroids, and they may have had an effect, but we're not kind of winning here. High flow oxygen, sure, we've already got that going. Salbutamol, salumedrol, yeah, we can do all of that. But let's say we've done that. Okay, we've done our ipratropium bromide and salbutamol, or Atrovent and Ventolin, and we've done our corticosteroids. We've done our mag sulfate even. What's left? This patient's already on a non-rebreather at high flow oxygen. So I think our best option here is to think about CPAP. But here's your kind of teetering edge of CPAP. Oops. Is that when you use CPAP, there are negatives. What's the negative of using CPAP in this patient? Or what's the potential risk of using CPAP in this particular patient? Go ahead, put that in the comments. Or any type of non-invasive ventilation, particularly CPAP, but what's the risk of using CPAP here? Anyone have any guess? The BP is low. It's going to drop the BP. Well, it might help get rid of the CO2. It's not going to directly get rid of the CO2. You're absolutely correct. But by opening up the bronchioles with the CPAP, it actually is going to hopefully improve airflow. So we do think that eventually it will help get rid of the CO2 indirectly, because it's going to help with airflow. But you're right, it doesn't directly help with that. It kind of indirectly helps kind of the body manage that. Another thing that you could do is you could attach your salbutamol and ipratropium bromide to the CPAP, because there's a difference between passively giving it through a neb, where you're depending on the patient to be able to breathe that in and get it low into the lungs to get some help and actually work. There's a difference between that and CPAP actually bringing it into the lungs itself. So there might be a combination of salbutamol ipratropium bromide with CPAP that could benefit this patient. Now, keep in mind, though, is that this patient has a pretty soft blood pressure and a high heart rate that's basically holding that blood pressure together. It's holding it like literally by its fingertips. So what can we do in this particular situation is, yes, use CPAP if you can, but understand that there are risks to it doing it. There's no contraindications in this particular situation, but giving it here has a fair amount of risk. Okay? So CPAP might help in this situation. I would say that CPAP would have helped a heck of a lot more if we used it earlier on. Now that we're kind of down to this kind of like the nitty, kind of the teetering edge, I feel like CPAP potentially could do more harm than good or has higher risk potential because of where we are. So if you're thinking about CPAP, you want to pull the trigger on using CPAP earlier with this patient than now, will be my advice. Why CPAP, not BiPAP on that patient? I'm with you there. So the reason I say that is because in EMS, which is kind of what I'm talking about as a whole for paramedicine, is that CPAP is far more readily available than BiPAP. And so the reason I'm using CPAP as my example is because that's what's used in EMS as opposed to BiPAP. The BiPAP devices that are available are all Venturi style, so they're not direct fan turbine driven, which means that you're not actually assisting ventilations. You're just changing inspiratory and expiratory pressures based on the movement of that patient. And so it's not as effective as actually having a ventilator with actual BiPAP. This device, CPAP itself, is at least going to drive some air. Which is why, and the fact that it's more readily available is why I'm kind of picking on it more than BiPAP, but it's a great question. Okay, so we have our CPAP, but like I said, earlier rather than later is you're better off. Okay, so which leads us to kind of where this patient is likely going. And that is that we have a 30-minute transport. And I guess my question to you is that do we have enough time, do you think, or what do you think the chances are that you have enough time to get to the hospital without this patient severely deteriorating and needing to be intubated before you get there? So I guess my question for you is, should you intubate this patient? Based on the vitals that you see here, and let's say CPAP didn't benefit this patient because they were too far down or too far gone, should you at this point be considering or seriously considering intubation? What do you think? What do you think? Should you be considering intubation for this patient? I'm going to leave it up to I haven't seen any comments yet, so I'm just going to wait. Luke thinks yes. Delayed sequence with epi and ketamine. I'm open to that suggestion. Yeah, I like it. Check ketamine. Jesus, I like the name too. But yes, I am open to that suggestion as a delayed sequence intubation. I think that's probably your safest bet. Paul's thinking yes. User 89610395075766587 is thinking RSI. No RSI. I know that you kind of. What about DSI? Do you have the option of DSI? Delayed sequence intubation? Because I think it is probably the safer route for this patient. So what do you think? Okay, so I personally think that you're probably looking at a better bet with this patient if you seriously consider intubation. Now, to do that safely and to do that properly, I think that you need to think about two particular things. One, you need to think about the blood pressure, and two, you need to be thinking about oxygenation. Okay, this is why I think that delayed sequence intubation is probably your better bet, because that revolves around using CPAP and BiPAP for oxygenation and then a nasal cannula underneath. So basically just getting all of the oxygen on board. Because I can tell you right now is that if you try to intubate with this number right here, you're in trouble. You're in a lot of trouble. So let's talk about the sequence of this and basically trying to get this patient as high of an oxygenation as possible. So first off, your blood pressure is not going to sustain at 110 when you start to go down that route. So it's going to drop. And so you need to seriously consider having an epinephrine push dose. And then also, if you have the ability, epinephrine drip. I think that's kind of the first thing that I would be seriously considering with this patient. Or norepinephrine. Okay, if you have norepinephrine, sure. But that's one thing they need to do it because you need to support that blood pressure. The second thing that I'd be considering is oxygenation. Because if you try to intubate that patient without oxygenating them, that 93% is going to go to 60 in about 3 seconds. So using CPAP as your bridge is essentially going to help that oxygenation. Using a BVM is going to help that oxygenation with a PEEP valve. It's going to help that oxygenation. And so with this patient, get a nasal cannula underneath and either use CPAP if they'll tolerate it or a BVM if they'll tolerate it. Because clearly passive oxygenation with a non-rebreather is not helping. So we need to get more. Because you want to get this number as high as you possibly can before you intubate. And so my suggestion would be, if you're going to intubate, a DSI route is probably the best route to go. And thinking about getting the oxygenation as high as you possibly can before you do it. Okay? And then the second thing is think about the blood pressure. Because that blood pressure will go down. And so having an epi drip is probably your best, or a norepi drip is your best bet. Because this patient is going to drop their blood pressure, it's going to drop their oxygenation even further. This is a scary patient to intubate, especially at this point. The idea with intubation, especially COPD patients, or any patient for that matter, is to pull the trigger on intubation far before these vital signs. Okay, that would be my suggestion. Is that you want to pull the trigger on CPAP earlier, and you probably want to pull the trigger on intubation earlier before you see this. Because once you're here, it's very, very difficult to get them back in a safe manner. And so making those decisions a little bit earlier and being more proactive will be a benefit to these patients. Okay, that was how I'd approach this. Any questions with this particular patient? Go ahead, throw them in the comments. What about dopamine instead of epi? No. You still have dopamine in your protocols. I would say dopamine, if it's literally the only thing that you have, I hate saying use it, because there's just no evidence to suggest that dopamine is really a benefit with these patients. But if it's all you have, I guess so. But I really hate to say use it, because it's just not. It's not a benefit. There's no evidence to suggest that it's a good vasopressor. Well, that's a good question, Eric. So he's talking about how would you deal with the underlying bronchoconstriction once the patient is intubated as the B2 stimulants were not working. So the B2 stimulants, remember, is that you have a couple things going on here. You have the B2 or the beta-2 stimulants that are only probably not working is because they're not actually getting into the bronchioles where the constriction is occurring. So you may actually, once you get them intubated, then you have a direct line and positive pressure to get it lower in the bronchioles where you might see more of a benefit. So once you get them intubated, I do not recommend stopping your beta-2 agonist and trying to get more atropine down into those lungs and try and limit the constriction that's occurring. Another thing too is that your ketamine that you would probably use for a DSI has a bronchodilation promotion. So that's a good news too. So it could relieve some of that pressure. The third thing that I would say is that your epinephrine, again, is a beta-2 promoter. So it'll actually cause bronchodilation. And so there's a few things to your benefit there. But you're right, this is a tricky patient. But I would suggest that once they're intubated and you still have bronchoconstriction, don't stop the bronchodilators. Keep them coming so that way you can continue to get those bronchioles open. Great question. Let's see what other questions you got here. What if you can't RSI or DSI? Then I would suggest so a lot of you are saying, what if I can't RSI and DSI? That's a great question. And so how I would handle this if I didn't have that tool is that this patient should be on CPAP about 20 minutes earlier. Okay. And so that your CPAP can be a very nice bridge to avoid these things from happening. Not all the time, but some of the time. So in this particular situation, what I would suggest in a COPD patient where your first and maybe your second round of bronchodilators are not hitting as well as you would want them to, CPAP. I would say if your first round of bronchodilators are not effective or are not working, CPAP. The more aggressive you are with CPAP and the earlier you use it, the more likely it's going to benefit the patient. And so if you don't have DSI and RSI, my advice to you is to limit the likelihood that you would need it. And the way that you limit that is by using an aggressive tool like CPAP as early as possible. Any other questions? Hopefully that answers your question there. I think you're good there. I don't see any more here. I got one more thing to talk about. We don't carry CPAP. We just call backup for. Yeah, like Paige, I feel for you. Like CPAP is a huge benefit to your patient. If you want, you can shoot us a message and be like, hey, is there anything that I can give my my medical directors to suggest that we carry CPAP? That's what I would say, is that you can shoot us a message and let me know kind of like, hey, is there anything that you can give me? And I can totally send you some stuff that maybe you can present to your medical directors or your training officers to provide it. That's kind of the best thing I can do, because honestly, CPAP is super effective. What would you consider effective response for bronchodilators? What I want to say, what I want to see from these people is I want to see a reduction in this CO2 number and an increase in this oxygen number. And if I have those things, then probably I'm going to help these things. So what would I see as a good response is that what I'm going to do is I want to throw a nasal cannula and tidal CO2 on these patients as early as possible to get a baseline CO2 and a baseline saturation from your sat probe. From there, then I start doing the treatments. And when I start doing the treatments, I'm literally going to be watching these numbers to see how they respond to my treatments. I give them Ventolin and Atrovent, then I'm going to see how my EtCO2 is doing, because this EtCO2 number is going to tell me how my airflow is. And is it getting better or is it getting worse? Is that number going up, which is worse, or is it going down, which is better? It means that airflow is better. So that's how I'm going to be seeing how effective my treatments are, is using a baseline EtCO2 from a nasal cannula EtCO2, so that way I can determine how well these patients are doing. Great question. Hey, the oxylog does the trick, right? I'm totally all for the oxylog. Okay, so the oxylog is better than nothing. The Sparrow is better than nothing. There's a lot of different devices out there. Like the Hamilton is $50,000. So not every service is ever going to get that. But there are alternatives that can be just as beneficial to ground ambulances than having a Hamilton that's quite complicated, right? So we already talked about that. All right, so we talked about questions, and so don't forget that, yes, we are hosting a conference, a paramedic conference. I'll be there. The people from Flight for Jed will be there. A bunch of other people that we're about to announce will be there, and you will be able to meet them all at our conference at FastCan, which is going to be in Calgary, Alberta, in September 2nd to 4th, 2025. If you want more information on that, you can shoot us a message. I'll send you the links. That way you can take a look for yourself, and you can hold your ticket for $5. And then when we actually release the tickets in November, you'll get first chance at those tickets before the entire public if you have a holded ticket. So definitely check that out. There will be group pricing. There are direct flights to Calgary from the UK. There's direct flights from Dublin. There's direct flights from Edinburgh. There are direct flights to Calgary from pretty much any major city in Europe and North America. So we would love to see you there. And if you're interested, shoot us a message and I will certainly get you the information that you need. Okay? Thank you so much for joining me today, and we will talk to you next time. Bye for now. Would I consider nasal intubation? Potentially, maybe. I just have other tools that kind of lead me up there. And I would be honest, William, that I don't have a whole lot of experience with nasal intubation because I've always had the exposure to DSIs and RSIs. So I can't really say that that would be high on my list to do. But yeah, I could definitely see the benefit in this patient, especially if you don't have DSI or RSI. Great question. What are the possible lung sounds this patient could present with? I would say that COPD often is going to present with restricted or obstructive sounds. And so wheezing is going to be your most likely sound that you'll hear in COPD. We'll be in Calgary September 2nd to 4th, 2025. Coming to Calgary, yeah. So shoot us a message if you're interested, and we'll send you the link. When you're making the jump to BiPAP, if CPAP is ineffective and you're unable to if you have the true capabilities, Jake, of BiPAP early, then I would use BiPAP over CPAP. If I had true BiPAP, means with a ventilator-driven BiPAP. What else? You're very welcome, Paige. Oh, awesome. Thanks, Heathen. Heathen Medic? Great. Yeah, it's super good, Sam. I used the Oxylog for years. Yeah, for years. Is it only the US that has critical care flight nurses? We have a few here in Canada where we use flight nurses. Like, it's not as common in Canada to use flight nurses, but we do have them. And then flight paramedics are probably your more dominant flight personnel. But the US, lots of critical care flight nurses. I believe the UK does as well. I could be wrong about that. I don't see any more last lingering questions. Eric, I would rather... Oh, good. That's great to hear, Michael. I feel for you. I've been thinking about you guys and watching the videos. It's been pretty crazy down there in Florida. Can you quickly explain DSI? I will do that on my next case study breakdown. How about that? Because I think that DSI is such a complicated topic. I would rather more time to explain it than a few minutes. But basically the idea is to use non-invasive ventilation through your pre-oxygenation phases with the assistance of ketamine. But like I said, I need more time to show you in whole, and something that I'll be talking about at FastCam. All right, I think I got it. Yeah, James Boomhauer is going to be at FastCan as well. I see him stay fit for duty. I'm not even sure if they allow you into Canada, but you're going to have to check on that. Okay. All right. I'm going to go before I start just digging at James here. Okay. Cheers, everyone. We'll talk to you soon. Will FastCam be virtual? It will not be virtual. No, it will be. It will just be in person. Okay. Take care, everyone on Facebook. Talk to you soon.